Abdominal pain, that's what we'll start out with. Very common in childhood. It's divided into acute and chronic abdominal pain. When you think of acute abdominal pain, probably the most common is going to be an acute gastroenteritis. Is the most common cause of acute abdominal pain in children. And we'll talk about gastroenteritis in a little while. It's kind of like an introduction. Again, remember, reading the test question, look at the age of the patient. When you're reading the test question, it will help you to formulate a differential diagnosis. And we're going to go through some of these things in a couple of minutes. So look at the age of the patient. Very important when it comes to abdominal pain, the sex of the patient as part of your differential diagnosis. Abdominal pain, when you're reading the question, look for the quality of it. Is it localized? Is it diffuse? Where is it located? Is it periumbilical? Is it right lower quadrant, left upper quadrant, wherever? So when you're reading the test question, you are basically getting your history, and so you need to look for those things to help you, again, with your differential diagnosis. Diagnostic tests. For generalized abdominal pain, there really, many times, is not one best test. Now, when we talk about the certain particular pathology, we will mention certain best tests, like when we talk about intussusception and things like that. But for a general abdominal pain, until you get more history and you formulate your differential, there's really not a best test right off the bat. CBC helps, right? But let's just say, when somebody comes in and tells you they have abdominal pain, what kind of questions do you ask? How long has it been going on? Okay. How did it start? What kind of what? What does it feel like? Now, that's a good question, but a lot of times children won't give you a great answer. They say, it hurts. Well, what does it feel like? Hurts. Okay, so you can use like a scale of 1 to 10, things like that. What else do you ask? Is it what? Where is it located? Okay, what else? Other symptoms. Is there vomiting? Is there fever? What else? Diarrhea. Anorexia. What makes it better? What makes it worse? Okay, all these things are helping you in your differential. So you need to be looking for these kind of things when you're reading the question, okay, just as if you had the patient in front of you. And then you start ordering some labs, because as you work in your differential, you start thinking, well, it could be this, and I'll order some labs. So the CBC may be helpful. A urinalysis is very helpful, because sometimes a urinary tract infection could be causing your pain. If it's applicable, a pregnancy test. That's why you need to know the age and sex of the patient. Serum amylase is part of your basic workup, because you have to rule out pancreatitis. Chest x-ray. Why do you get a chest x-ray on someone with acute abdominal pain? The pain's not there. It could be referred pain from a pneumonia. Okay? So a chest x-ray can be helpful. Abdominal films are helpful. And occasionally you need to go to CT scans of the abdomen. The differential diagnosis of acute abdominal pain, again, depends on your history, physical, and your ages. In children less than 2 years of age, what you should be thinking about is trauma, intussusception, incarcerated hernias, volvulus, and urinary tract infections, in addition to the acute gastroenteritis, which is the most common in any age group. 2 to 5-year-old children, you should be thinking of sickle cell anemia, a pneumonia, a lower lobe pneumonia, and urinary tract infections. Also a Meckel's diverticulum, and we'll talk about that a little bit later. In about a 2-year-old, you should be thinking of Meckel's. Always think of appendicitis. In adolescent females, Mittelschmerz, ectopic pregnancies, pelvic inflammatory disease. And then you have other causes such as pancreatitis, Henoch-Schönlein purpura. We'll talk about that later. Mesenteric adenitis, for example, we talked about strep pharyngitis yesterday, and we said that sometimes they can have abdominal pain, and that's usually from a mesenteric adenitis. Lead poisoning. Diabetic ketoacidosis can present with abdominal pain and vomiting. Renal stones, cholecystitis, these are all part of your differential diagnosis. Chronic abdominal pain. Now, chronic abdominal pain is a specific definition, just like we talked about fever of unknown origin being a specific definition, so is chronic abdominal pain. And it's 3 or more episodes of abdominal pain severe enough to affect your activities, and it occurs over a 3-month period. Chronic recurrent abdominal pain is a difficult evaluation many times. It occurs in about 10 to 15% of children between the ages of 5 to 15. And causes include constipation, lactose intolerance, parasites, inflammatory bowel disease, and always remember peptic ulcer disease. Children can get ulcers. Remember Helicobacter pylori, H. pylori, can cause abdominal pain, chronic abdominal pain in children. Pancreatitis, cholelithiasis are also causes of recurrent or chronic abdominal pain. A urinary tract infection, and these are the less common ones, abdominal epilepsy, porphyria. These are way down on the list. Makes you look good on rounds, though, okay?
What is abdominal epilepsy?
Abdominal epilepsy is basically, that's the manifestation of your seizure, abdominal pain. Non-organic causes of a recurrent or chronic abdominal pain in children include functional abdominal pain, also known as irritable bowel syndrome. Usually the child with the recurrent abdominal pain or the chronic abdominal pain has very nonspecific symptoms. And like I said, you ask them, what's the pain feel like? Oh, it hurts. But what does it feel like? It just hurts. Or they'll ask, where does it hurt? And many times they'll just kind of, oh, here, and they'll point to the entire abdomen. So very nonspecific symptoms. A history is very important. So if you're getting a history, you're reading the test question, and it tells you that this child is having episodes of abdominal pain, and they occur every school morning. Okay, so you're reading the question. It says they're in the mornings. They usually go away by noon or 1 o'clock. Doesn't wake them up at night. Doesn't affect play activity. Doesn't happen on weekends. Doesn't happen on holidays. Only happens on school days. Okay, so what do you think? He's got a school phobia or something. Maybe there's a bully. Maybe he's constipated, doesn't want to use the bathroom at school, so he has constipation from that, things like that. But so that kind of a history is very helpful in letting you know this is a recurrent abdominal pain, but it's probably because he doesn't want to go to school. So stressors such as school or exams, right? USMLE, step 2. Oh, God, that hurts. Okay? So a stressor like school or exams can produce a rather predictable pattern of abdominal pain. Relocating, moving to another house, another town, grandma's dying, things like that. Those are kind of stressors that will create, and it's a real pain. They really do feel it. Okay? Sibling rivalry. And then there's irritable bowel syndrome, which can present as a recurrent abdominal pain. It can produce pallor, nausea, vomiting, lethargy. These are real symptoms that they have. They can have diarrhea with irritable bowel syndrome. 30% of patients with irritable bowel syndrome will have nocturnal enuresis, fears, and sleep disturbances. And the parents themselves may have suffered from abdominal pains. Again, when you have a patient that presents like this with this chronic abdominal pain, there's not one single best test to prove it. The history and the physical is the best thing. Usually the physical is absolutely normal. Once you do that, you just basically need to reassure the parents that if you're convinced that it's recurrent abdominal pain. However, again, CBC, a SED rate is helpful. If it's absolutely normal, there's less worry about some organic cause. You could do a urinalysis. Same test you would do for acute abdominal pain, you can do for recurrent abdominal pain. Most of these studies are absolutely normal. Okay? Here's a few things that you can see with acute abdominal pain when you do your evaluation. And right over here, see that? What is that? Not a quarter. Okay, it's a little low to be a quarter. It's called a fecalith. So it's a little calcified piece of poop. Right? And that's in the appendix. So maybe this child has appendicitis. Probably does. So that's where the abdominal films may be helpful, or you might see something else on abdominal film like an ileus or whatever. And here you have appendicitis as a cause of acute abdominal pain. And there's your fecalith. Okay? And that's your appendix right there. So, a 13-month-old child has had a 3-day history of green, watery stools. She has also been vomiting for 1 day. Physical examination reveals a febrile, irritable baby with dry mucous membranes and sunken eyes. So, on physical exam, what's the child look like? What's your diagnosis from this physical exam? Dehydration. Very good. So now you can go back and do your problems from the 3rd chapter or whatever, right? So this child's dehydrated, and the cause of the dehydration, diarrhea, fluid loss from the stool. And what's the most common cause of diarrhea in this child? It's probably viral. And what virus in particular? Rotavirus. Okay? So diarrhea is defined as increased stool output with excess loss of fluids and electrolytes. And it can be acute or chronic. And there are several mechanisms listed there. And you may have one or more of those mechanisms causing your diarrhea. So we have secretory, and what that means is that you have decreased absorption and increased secretion. Osmotic, which is from maldigestion or transport deficits of unabsorbable solute. Increased motility means that you have, it should be increased transit time, not decreased transit time. Okay, if you have increased motility, decreased transit time. Decreased transit time? Should be. No, increased transit time means that it takes longer to go through. So it is right. Decreased transit time. That is correct, the way it is in the notes. Decreased surface area. So you don't have as much area for absorption, and that occurs many times after what they call short bowel syndrome. So for example, the premature baby that suffered necrotizing enterocolitis on our first day and had a significant portion of small bowel removed now does not have as much area for absorption, and so they can develop chronic diarrhea. Or you can have mucosal invasion. So from inflammation, decreased colonic absorption, and increased motility. So you may have one or more of these causing your diarrhea. And again, the causes of diarrhea in children will be age dependent. Really keep in mind rotavirus. Okay? The most common cause of wintertime diarrhea in infants and young children is going to be rotavirus. And typically they will have these watery, greenish stools, and they really stink. You smell a rotavirus stool, you'll never forget it. You can walk by and go, ooh, that's rotavirus. You don't have to order any tests. Okay? And again, remember that gastroenteritis, just like abdominal pain, the most acute abdominal pain, the most common cause is gastroenteritis. The most common cause of acute diarrhea in children will be an infectious gastroenteritis. And viruses being the most common. Also, you can have food poisoning. Some systemic infections can do this. Parasites can do it. And always remember antibiotics as a cause of diarrhea. So if you're reading a test question and it mentions that the child has been on antibiotics for pneumonia or otitis, then what are you going to think about? C. difficile. Okay, and you have a table there with acute and chronic causes of diarrhea, in different age groups. And see there that in the acute, number 1, in infant, child, and adolescent is gastroenteritis. In an infant, a systemic infection, so urinary tract infection can cause diarrhea, okay, and antibiotics. In children, you worry about gastroenteritis as number 1, you worry about food poisoning, and you worry about systemic infections. And in an adolescent, again, it's the same thing. Gastroenteritis, food poisoning, and systemic infections as your causes of acute diarrhea. Chronic diarrhea in children, in infants, worry about a post-infectious lactase deficiency. So for now they're not, and that's usually temporary, but it can last a couple of weeks, couple of months, and then it starts to come back. Also remember milk or soy intolerance. There's also a term called chronic diarrhea of infancy. When you're reading the test question, chronic diarrhea of infancy is typically a child who has watery stools every day and is otherwise fine. So characteristically, they're well hydrated, they're happy babies, and really important, they're gaining weight. And that's called chronic diarrhea of infancy. You don't need to do anything about it. So look for those characteristics. A happy baby who's well hydrated and gaining weight. And that's probably chronic diarrhea of infancy. Also, malabsorption like celiac disease and cystic fibrosis. We talked about it yesterday. You get malabsorption from cystic fibrosis and you will have a diarrhea. Those stools tend to be kind of bulky, greasy, fatty stools that float on top. In a child, again, post-infectious lactase deficiency. Remember irritable bowel syndrome. And then you have celiac disease. Lactose intolerance basically increases in incidence as you get older. Remember giardia as a cause of diarrhea in children, and inflammatory bowel disease. We'll talk about inflammatory bowel disease later. And in an adolescent with chronic diarrhea, like irritable bowel and inflammatory bowel come up higher in your differential, followed by lactose intolerance, giardia, and laxative abuse. So when you start having the 12, 13, 14-year-old girl who is worried about her body image and is purging and complains of chronic diarrhea, you have to suspect laxative abuse. Okay? So again, viral agents, rotavirus is the most common. Also remember adenovirus and the Norwalk viruses. Bacterial causes include E. coli. And what's the most famous recent E. coli? The 0157, right? And we'll talk about hemolytic uremic syndrome in a minute. Also remember salmonella. With salmonella, you're going to have you should look for a history of what? Undercooked poultry or eggs or turtles. Okay? So if they have a pet turtle, they can get salmonella. Okay? So remember that when you're reading your test question. Pet turtle or poultry that's undercooked or raw eggs. Shigella, Campylobacter, Yersinia, Clostridium are all bacterial causes. Parasitic causes are amoebic dysentery, or Entamoeba histolytica, remember giardia, and crypto. So let's rotavirus. Rotavirus will have a watery diarrhea. It can last for a week or 10 days. And they can be accompanied by vomiting. So they can have vomiting and diarrhea with rotavirus. They may have some fever and they can get dehydrated, particularly the infants because they're a higher proportion of body water, and so they can get dehydrated. The E. coli will be seen in nurseries and daycare. Enterotoxigenic E. coli is the one that's responsible for traveler's diarrhea. And enterohemorrhagic E. coli is the one that can cause hemorrhagic colitis and a hemolytic uremic syndrome. And we'll get to that in a minute. All right, salmonella, like we said, eggs, milk, and poultry that's contaminated. And don't forget your turtles. Shigella and Campylobacter are usually person-to-person spread, and it's usually from contaminated food or water. So these are things that you would be looking for in the test question to help you differentiate between one pathogen and another. Yersinia, pets. Usually puppies, I think. And with Yersinia, they can develop an arthritis and a rash. C. diff, look for prior antibiotic use. And so then they'll say, what's the best test? And you're going to send for a stool for C. diff toxins. Okay? Staph aureus food poisoning. When you're reading the test question, look for a common source. So there will be an outbreak. It's usually within about 12 hours of eating. It's also short-lived with Staph aureus, but look for a common source, like the church picnic and everybody's having potato salad or something. Right? So look for a common source. There's not going to be just one person. It might be several people that come down with this. Entamoeba histolytica will cause an acute bloody diarrhea. Giardia, look for anorexia, nausea, abdominal distension. And Giardia, you can get a stool for ovocysts and parasites, right, and diagnose it there. Or you can do duodenal aspirates for Giardia. The old days used to do the string test, where you would just swallow like a capsule, which would dissolve, and it had a string in it, and then you just pull the string out, and you could check for Giardia. Okay, but look for duodenal aspirates, or look for the Giardia in the stool, and that's how you're going to diagnose Giardia in the stool. And Cryptosporidium, usually in immune-competent hosts, doesn't cause much problems, just a mild self-limited diarrhea. Crypto is very important, however, in patients with HIV. It's almost impossible to eradicate, and they will have this persistent chronic diarrhea from Cryptosporidium. Okay, diagnostic tests. Recover the organism from the stool. That's probably the best thing you can do. So you can send stool studies for cultures, for Salmonella, for Shigella, for E. coli, for Campylobacter, Yersinia. You can do all of these from stool studies. So the best test to diagnose these diarrheas are going to be stool studies. And C. diff can also be detected. It's not so much the organism, but the toxin with C. difficile. Okay? And the treatment. Treatment of diarrhea is usually supportive. Rotavirus, these viruses, you're going to get better from it. So you don't need all these antispasmodics and things that you give people. I won't mention any brand names, but you don't need to give them. Let them go ahead and stool. You need to take care of fluid losses. If they're getting dehydrated, you need to give them fluids by mouth. If they get sick enough, they need fluids IV. But generally, you don't want to give medications that, quote unquote, stop the diarrhea. They really don't. What they do is they slow down peristalsis, and you still have this big watery stool inside of you. So the stool frequency goes down, but it's still very wet stool. It's still liquidy. Okay? Salmonella. Treatment of salmonella will prolong the carrier state, so it is not recommended. And where does salmonella hide? When in the gallbladder. Very good. So salmonella is only indicated, treatment of salmonella is only indicated if the patient is less than 3 months of age, if they're really sick, or have disseminated disease, or if it's Salmonella typhi. Those are the only times that you treat the patient. Otherwise, you're going to prolong the carrier state. Shigella, you do treat with trimethoprim sulfamethoxazole. Campylobacter, you generally don't have to treat. It's usually self-limited, although erythromycin does help decrease the period that you're sick, and you're not going to spread it. You're also not as contagious. Yersinia does not require antibiotic therapy for the most part. However, if you are less than 3 months of age or you're septic, then you treat. And C. diff will be treated with metronidazole or vancomycin, and then you stop the other antibiotics. That's what's caused the problem. Entamoeba will be treated with metronidazole, and Giardia can be treated with metronidazole or furazolidone. Okay? But for the most part, you don't treat acute diarrheic episodes. Okay, constipation. A 6-year-old boy complains of hard bowel movements every 5th day. Physical exam reveals normal weight and height. The abdomen is soft and hard stool is palpable on rectal exam. So constipation is the infrequent passage of hard, dry stools. Obstipation means that you're not passing stools at all. Okay? Big difference. The most common cause of constipation is voluntary withholding, what we call functional constipation, outside of infancy. Obviously, an infant can't voluntarily withhold. Okay, so they're constipated for a different reason. But once you're like 6, 7, you're holding it in, it's usually functional or voluntary. And there's a lot of reasons for that. Constipation can occur secondary to defects in filling or emptying the rectal vault. Other causes of constipation. We already showed you an imperfect anus the first day. We talked about Hirschsprungs. That should always be entertained. We talked about Hirschsprungs when we talked a little bit about encopresis too, because you can have some liquid stool that kind of squirts around the obstruction. So Hirschsprungs, even though you pick it up usually very young, you can sometimes have an ultra-short segment, and these patients are picked up later because of constipation. Infantile botulism can also cause constipation, and that's why we mentioned no honey in the first year of life. With constipation, you'll have hard stools. Sometimes you can have liquid stool and then get encopresis, or it looks like diarrhea. Constipation in the neonate, always think of Hirschsprungs in the neonate. And how do you diagnose it? What's the best way to diagnose Hirschsprungs? Biopsy. Okay? And here you have a table that differentiates Hirschsprungs from functional constipation. Okay? So usually Hirschsprung starts at birth, and functional constipation greater than 2 years of age. With Hirschsprungs, you usually don't have encopresis. You may, but you usually don't. With functional constipation, you might have encopresis. With Hirschsprungs, you don't have failure to thrive. What's important to know here is there's usually a history of forced bowel training with functional constipation, like starting toilet training a little too early, which is really our own fault. The child will be toilet trained when it's ready on its own. Look at the physical exam, okay? Look at the physical exam for Hirschsprungs versus functional constipation. There's usually abdominal distension in Hirschsprungs. There's poor weight gain in Hirschsprungs. The anal tone will be normal in both of them. Okay? However, when you do a rectal exam, if you have Hirschsprungs, you will probably not palpate any stool. Why? Because the obstruction is a little bit higher. So you're going to do a rectal exam, no stool will be palpable in the rectal vault. That's an important characteristic. Whereas in functional constipation, you do a rectal exam and you will palpate some hard stool right there. Okay, you can barely get that finger in, you're palpating hard stool already. And that's what's in this particular question. The abdomen is soft and hard stool is palpable on rectal exam. This child probably has functional constipation. Okay? So that's an important characteristic, and that'll show up on the exam question. That's one way you're going to go one way or the other, is by the palpating the stool. Okay? Diagnostic tests for Hirschsprung, if you suspect it, you're going to go for the biopsy. You can do manometry for functional constipation. You can do biopsy in functional constipation, but you shouldn't have to go that far, and you'll find that they have ganglion cells everywhere. Okay? So the rectal exam is big key here on the physical exam. This is celiac disease, I believe. Yeah. So we haven't gotten to that yet. All right, vomiting. Causes of vomiting celiac disease can cause diarrhea. That's why we have it up there. I knew it was I'm not out of whack here. So with celiac disease, you can have diarrhea. With celiac disease, you will have some bloating because of the malabsorption. You'll have the diarrhea. This is a patient with celiac disease, and you see the wasting of the buttocks. This is because they have failure to thrive. They will have chronic diarrhea. This is a patient with Hirschsprung's. Look at the abdominal distension. It's all full of poop. And if you do a rectal, you're not going to feel any stool in the rectal vault. Okay, causes of vomiting in children. In the neonate, a child that's just vomiting, you should be thinking of some kind of an obstruction. Okay, either it's a volvulus, malrotation, something like that. If it's just vomiting in the neonate. If they have vomiting and diarrhea, that might be a little bit different. But just vomiting in the neonate, think of obstruction. In infants and up, you should think of gastroenteritis as your cause of vomiting. Although in infants, part of your differential includes GE reflux, food allergies, milk protein intolerance, overfeeding. So if your stomach only holds 3 ounces and they're giving the baby 5 ounces every 2 hours, it's got to come out. So overfeeding is a problem. Or inborn errors of metabolism. We talked about galactosemia. We talked about phenylketonuria producing vomiting. So that's part of your differential diagnosis. In children and adolescents, vomiting, think of gastroenteritis first, and then systemic infections or toxic ingestions that can cause vomiting, or appendicitis, ulcers, pancreatitis. Okay? Okay, a newborn presents with bilious vomiting with every feed. Bilious vomiting. Abdominal film reveals double bubble. Now, we saw this the first day, right? We saw the abdominal film the first day. We talked about duodenal atresia. Okay? So look for a newborn, that's the key, bilious vomiting. That's the other thing you're going to look for. And that right there, you should be suspecting duodenal atresia. Don't forget, if they'd be too nice to throw in if the child has trisomy 21. That'd be just too nice in the test question. It's a higher incidence of trisomy 21. So again, it'll present early, usually the first day of life, with bilious vomiting. There's no abdominal distension, and the abdominal film shows the double bubble. That's the giveaway. And the treatment is call the surgeons because they have to correct that. GE reflux. A 4-month-old is admitted with episodes of apnea occurring 20 to 30 minutes after feeds. That's the important clue right there. The mother states the baby has been spitting up since birth. She is at the 5th percentile for weight. Now, GE reflux, most babies will spit up a little bit. Okay? GE reflux is a problem when they're not gaining weight. So there's a key there too. So that question is a lot of information in it. First of all, the episodes of apnea occur about a half an hour after the feeds. And the baby's been spitting up since birth, and now the mom tells you that that the baby's not gaining weight well. So there's a significant GE reflux. What happens with GE reflux? Well, the lower esophageal sphincter pressure is reduced, or there's inappropriate relaxation of the sphincter, or there's a hiatal hernia, or there's delayed gastric emptying, which can cause things to back up. When things back up quite a bit, the patient will have, remember when we talked about dry drownings? And we said that first you have a laryngospasm so you don't aspirate? Well, the same thing can happen with GE reflux. Basically, they're refluxing and you have like a laryngospasm and they can have apnea. Or they can actually aspirate. And then they have coughing and wheezing and things like that. So they can have aspirations with GE reflux. So patients, a lot of patients will have GE reflux. Usually it doesn't mean a whole lot. Again, you pay attention to poor weight gain. Patients with developmental delay and cerebral palsy tend to have more reflux. The symptoms are varied. They can have some kind of spitting up. They may have forceful vomiting where the parents will say it gushes out. Apnea many times is the presenting sign. look for chronic cough and wheezing because they're aspirating basically. And if they're having poor weight gain, that's significant. Now, there's a particular entity called Sandifer's syndrome. And those are patients who have GE reflux and they assume a particular position of epistatonus. So they're going to arch their backs and their heads, so there'll be epistotonic, and that's called Sandifer syndrome. And basically, that's like a reflex or a mechanism so that they try not to aspirate or it hurts because of the reflux, and they're trying to help relieve the pain a little bit, so they'll assume that posture. The best way to diagnose GE reflux is a pH probe. Okay? So if you suspect, they'll say, this particular baby, a 4-month-old is admitted, blah, 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 she's at the 5th percentile for weight, you suspect GE reflux. You're going, oh gosh, I thought that was the answer. They're giving it to me. Your next step would be, and they'll start talking about things. If you're going to diagnose it, your next step is going to be a pH probe. If you're going to treat it, then you can pick anti-reflux measures, thickening the feeds, medications, things like that, prokinetics, all these things. Okay? So if you're going to diagnose it, you look for pH probe as your answer. What it does is it's a pH probe that they put in the distal third of the esophagus, and it measures overnight the pH, and if the pH drops too low for too long a time, you've got your diagnosis of reflux. That means that you've got gastric acid coming up and lowering the pH. Other studies include technetium scanning, many people call it a milk scan, or some people will use barium swallows, but the best test is going to be a pH probe. Therapy consists of anti-reflux measures, like elevating the head of the bed, thickening of feeds by putting like cereal into it. You can use antacids, prokinetics, H2 receptor blockers, protein pump inhibitors. And then if that fails, then you go to surgical management, which includes the Nissen fundoplication, where they kind of bring the stomach up and make a cuff around the esophagus so things don't back up. Okay? Majority of patients will get better without any treatment as they get older. But the ones that, like I said, they're not gaining weight, having problems with apneas, they're more significant. Okay? All right, this is pyloric stenosis. This is not a baby that's been doing a lot of abdominal crunches. Okay? And what you see here is what's known as the peristaltic wave. So this question, a 4-week-old has non-bilious. All right. So we talked about duodenal atresia, bilious. Pyloric stenosis, non-bilious. That's how you're going to tell them apart. And you should always be looking for the color of the vomitus when you're reading your test question. Non-bilious projectile vomiting. Exam is remarkable for a small mass palpated in the abdomen. Okay? So pyloric stenosis is a gastric outlet obstruction. It's going to be more common in males. That's why the question says a 4-week-old boy. It's more common in firstborns, and there seems to be some genetic predisposition. If you have a child with pyloric stenosis, you have a 5% chance of having another child with pyloric stenosis. If the mother had pyloric stenosis, however, there's a 25% chance of her having a child with pyloric stenosis. The odds go up immensely. Okay? So look for non-bilious projectile vomiting. Usually starts at around 3 to 4, sometimes 2 to 4 weeks of age, but the classic will be around 3 to 4 weeks of age. The baby is still hungry after the vomiting because the stuff came out. It's very forceful. The parents will tell you it gushes out, it shoots out, it's like a hose, okay? Like The Exorcist. You may palpate an olive on physical exam, and you may see this peristaltic wave. Sometimes they'll be jaundice. They may have some weight loss, and they may show up dehydrated. The best test, once you suspect pyloric stenosis, is an abdominal ultrasound, because it's non-invasive. You can try a barium swallow, but now you've got all this barium sitting in the stomach that you have to suck back out. So an abdominal ultrasound is the best test once you suspect it. Other lab findings include, and this is a classic, hypokalemic, hypochloremic, metabolic alkalosis. You better know that. Okay? So let's look at some pictures. So here's the barium. Actually, we had a child come in last week, and they did I guess they didn't have the ultrasound at the other hospital, or who knows, and they did this, and they're just beautiful pictures. It looked just like this. So here you see a big distended stomach. You have here what's known as the string sign. See it? And that's the pylorus. It's going to be elongated, and since the muscle is hypertrophic, it's a very small outlet, and so you get the string sign, and then you get what's known as the mushroom cap, or the umbrella, as the stuff kind of squirts out once it gets past the pylorus, because some of it does go through. So there it is. There's your string sign. There's your mushroom, and now it goes into duodenum. Here's a great-looking mushroom. Oh, my goodness. Saute that guy up. Okay? And there's your string sign. Looks like an umbrella, too, but I like mushrooms, so. Okay, ultrasound. On ultrasound, well, here's another string sign blown up. Okay? And there's your ultrasound. And this black part right there, that's the muscle. And then this is the opening. And what the radiologist does is they measure this, and then on the other axis, they'll see how long it is, and they have certain measurements, and then they'll say, oh, it's pyloric stenosis. So that's the best test right here, is an ultrasound. And here again, they call this maybe a donut, too. They're always thinking about food, radiologists, food and drink. Okay, so there you see the hypertrophic muscle, and then that's just the opening. And so they'll measure this, and the long axis of it. Okay? And right here. See how hypertrophic that is? Now, usually you don't need to do this. Okay? The treatment is surgical. First of all, you're going to rehydrate them if they're that dehydrated, correct their electrolytes, and then you will do surgery. And you just do a little pyloromyotomy, and 8 hours later the patient is eating again. Okay? Okay, this is a table. You have a table in your notes for GI bleeding. GI bleeding can be described, and you have definitions. Hematemesis, which is blood-stained vomitus, so it means that it's usually upper. You have melena. Those are soft, black, tarry stools. That can be from anywhere. Bleeding from anywhere can result with melena, anywhere along the GI tract. And then hematochezia is bright red stool, so that implies that it's usually lower in the GI tract, although since infants have a very rapid transit time, or children have a very rapid transit time, and blood in and of itself is a cathartic, it's sometimes bright red blood coming out could be from higher up, but generally it isn't. So keep those three in mind, because they're going to use those terms in the question, and that right away you'll be saying, okay, this is probably upper. Oh, no, this is lower, depending on what word they use, whether they use melena, hematochezia, or hematemesis. And that tells you pretty much the location, so you need to know that for the question so you know where it's coming from. Again, you need to know age groups, because depending on the age group helps your differential as far as what's the cause of the bleeding. And so this slide is similar to your table. Less than 1 year of age, upper GI bleeding, you should think of gastritis or swallowed maternal blood. And when you think of swallowed maternal blood, what's the best test to find out? The swallowed maternal blood would be in the neonate, okay? So they might say that the infant, the neonate, is passing some bloody stools, and you should think of the APT test. APT. That's the best test to let you know whether this is swallowed maternal blood that the baby is passing or if it's the baby's blood. What the APT test does is it will differentiate between fetal hemoglobin, And if it's fetal hemoglobin, it means it belongs to the newborn, and so it's his problem, versus adult hemoglobin. And if it's adult hemoglobin, then it probably is swallowed maternal blood. So you need to know the apt test. That's the most apt test for diagnosing if this baby has swallowed mom's blood. That can come from the delivery, or maybe mom has a cracked or bleeding nipple, and the baby swallowing blood when it nurses. Now, babies are less than 1 year of age also think of ulcers or malrotation and volvulus. As far as lower GI bleeding in a less than 1 year old, anal fissure is number one. And I think there it is, anal fissure. Right there's a little tear, and that's the most common cause of lower GI bleeding in a child, in a patient under 1 year of age. An anal fissure from irritation, from diarrhea, or from a hard stool that tore a little bit, so an anal fissure. Also, intussusception, necrotizing enterocolitis, we already talked about NEC, and malrotation or volvulus. Greater than 1 year of age, think of peptic ulcers, think of varices or gastritis for upper GI bleeding. For lower GI bleeding, greater than 1 year of age, a polyp or intussusception or a Meckel's diverticulum, and we'll talk about some of these in a minute, or diarrhea causing blood, we already mentioned it can cause blood, or inflammatory bowel disease or a hemorrhoid. Okay? So let's mention inflammatory bowel disease. A 13-year-old girl complains of chronic cramping, abdominal pain, and diarrhea. She has noticed occasional blood in her stools. She has had fever off and on for 3 months, fever of unknown origin, and has complained of persistent right wrist pain. CBC shows anemia, and her SED rate is elevated. So inflammatory bowel disease, you should think of Crohn's and ulcerative colitis. The two of them comprise inflammatory bowel disease. And both of them are going to be characterized by exacerbations and remissions. They get better, they get worse, they get better, they get worse. Look for onset during adolescence. So that's why the question here says a 13-year-old. You're not going to have too many 4-year-olds with this. Okay? So look for an adolescent when you're reading the question. And although it's not, you don't know exactly what causes it, it's more common in people of Jewish descent and in whites. It will run in families. All right, so Crohn's. I don't think I have any. Yeah, I do have Crohn's. There we go. This is Crohn's. So Crohn's, there's like a, see how thickened this is? Very thick. So Crohn's can have insidious onset and has more extra-intestinal manifestations than ulcerative colitis. So this girl, if you had to pick, has Crohn's. Why? Because she's got her wrist pain, right? She's got, well, anemia can be in both of them, but she's having extra-intestinal manifestations like an arthritis, which is very typical with Crohn's. So they can have fever of unknown origin, they can have arthritis, they can have skin manifestations, weight loss from chronic disease and basically like a malabsorption, abdominal pain, a cramping abdominal pain, diarrhea, and sometimes bloody diarrhea. And perianal disease is common, although Crohn's can affect anywhere along the GI tract, whereas ulcerative colitis, by the term colitis, is relegated to colon. SED rate is usually elevated. The platelet count is high because it's an acute phase reactant. Abdominal films can show small bowel obstruction. And upper GI will show thickened folds and narrowing of the GI tract. And if you were to put barium here and take films, then you'd see this would be a string sign, just like we talked about pyloric stenosis. This is also a string sign. With Crohn's, you also see what's known as skip lesions. So there'll be an area that's affected, there's an area that's okay, there's another area that's affected. So those are called skip lesions. Crohn's is also notorious for fistula formation. And colonoscopy and biopsy are the best way to diagnose Crohn's. So endoscopy with biopsy is the best way to diagnose Crohn's. You can have your SED rate, you can have your films and all. The best thing is to go ahead and do an endoscopy and a biopsy. Treatment will be aimed at relief of symptoms. That includes steroids, aminosalicylates. So you do use salicylates in this case. Sometimes you even use salicylate enemas. Chemotherapy such as azathioprine, metronidazole can be used for fistulas. Patients will sometimes go on cyclosporin, immune suppression like tacrolimus, and tumor necrosis factor alpha is also used in Crohn's disease. Antibiotics can be used because many times they have an ongoing infectious process or you can't tell the difference, so you treat empirically. Hyperal is many times used because these patients are chronically ill. They can have diarrhea and malabsorption, so they need calories. And sometimes the only way to give it to them is through Hyperal, and at the same time you're resting the gut. Because if you've got all this inflammation, why eat? First of all, the patient won't want to eat, and secondly, it makes things worse, so you rest the gut and you put them on Hyperal. Surgical management is reserved for failure of medical management, for fistula formation, intestinal obstruction, and growth failure. Complications, again, remissions and exacerbations. You can have GI obstruction as a complication, malabsorption as a complication, anemia of chronic disease, anemia from blood loss, growth failure. All of these things can happen with Crohn's. And your differential is going to be an infectious enteropathy, recurrent abdominal pain, arthritis. Remember, they can present with arthritis and leukemia and ulcerative colitis too. Okay? Let's finish ulcerative colitis and we'll take our break. Let's see, do we have anything else on Crohn's? No. So ulcerative colitis is limited to the colon. It can be insidious or fulminant, and there's a mild, moderate, and severe form of it. Look for bloody diarrhea with mucus. So part of your differential diagnosis could be some infectious cause that can cause of bloody diarrhea. Abdominal pain, tenesmus, which is straining at the stool, can be present. Mild to moderate disease is the most common manifestation, but they will have about 6 stools a day, no fever, usually no anemia because there's not a significant blood loss. Moderate disease will present with some anemia because of blood loss in the stool, and in severe fulminant disease, they can have bad enough anemia that you have to transfuse them. They can also have high fevers, leukocytosis, and tachycardia. Again, ulcerative colitis is a diagnosis of exclusion. You need to have symptoms for 3 to 4 weeks before you can start entertaining it or thinking about it. The SED rate is not helpful. I mean, it could be elevated, but that doesn't mean anything. SED rate's a nonspecific test. Anemia will be present with severe chronic disease. Endoscopy with biopsy. That's what's going to give you the answer. So that's the best test. You will not see skip lesions with ulcerative colitis. Therapy is similar to Crohn's. Okay? Aminosalicylates, sulfasalazine are commonly used. Steroids, also used. And surgical treatment, if it comes to that, failure of medical management, you go to surgical treatment, which is total colectomy. And you have a table there that kind of differentiates one from Crohn's from ulcerative colitis as far as the symptoms that you'll see, fistula formation, skip lesions, things like that. All right, so we talked about things earlier I said we're going to get to later. Now we're going to get to some of these things, like intussusception. A 15-month-old child is seen for cramping, colicky abdominal pain of 12 hours duration. He has had 2 episodes of vomiting and a fever. Physical exam is remarkable for a lethargic child. Abdomen is tender to palpation. Leukocytosis is present. During exam, the patient passes a bloody stool with mucus. All right, so we have a patient with abdominal pain, acute abdominal pain, right? Colicky abdominal pain of 12 hours duration. So we know it's acute. The age is important. He's 15 months old. We've had some vomiting, so you could be thinking, okay, it's a gastroenteritis, big deal. But this patient looks a little bit sicker. Okay? He's lethargic. The abdomen is tender to palpation. And he has a bloody stool. You've got to pay attention to that. So in this age group, you have to really consider intussusception. So again, the age and the presentation. It's acute, it's in the right age, and he's had the bloody stool. Those are very important keys for intussusception. What happens in intussusception is that part of the intestine, the intussusceptum, telescopes into the intussuscipiens, into the distal part. Okay? And usually it's going to be ileocolic, but it can happen anywhere. Usually there's not a known cause for intussusception. You can find something, we'll talk about that in a minute. The peak age, now this child is 15 months old. Usually it's between 6 to 24 months of age. It's been reported in children as young as 6 months, 3 months, and as old as 6 years. The oldest I've seen is a 5-year-old with this. Okay? But usually 6 to 24 months of age. So this child's 15 months, falls right into that category. There has been some association with lymphoid hyperplasia, with Meckel's diverticulum kind of being the lead point and pulling the intestine along. Also, a lymphosarcoma or polyps or cystic fibrosis, and Henoch-Schönlein purpura has also been associated with intussusception. The rash was of Henoch-Schönlein purpura in this particular patient. So, that can be part of what's causing your intussusception. It can just, the thickening from Henoch-Schönlein purpura can be a lead point. So, whenever a patient has intussusception and the surgeons go in, they need to check the entire intestine to look for lead points, such as polyps, to see if anything caused this intussusception. Look for, another important association, rotavirus vaccine. Now, we didn't mention that during the vaccination talk, and that's because we don't give it anymore. So, instead of rotavirus vaccine, also look for a preceding history, or a history of a preceding gastroenteritis. So this child may have had rotavirus a week ago or so, and now has recovered from it, and now presents with this intussusception type picture. On physical, the history, look for acute onset of vomiting and a colicky abdominal pain. What that means is it's pain that comes and goes. It's relieved for a little while, and then it starts up again. They may have vomiting. They may develop fever. They may become lethargic. And look for this description in this question was a bloody stool with mucus. That's also known as a currant jelly stool. Currant jelly stool. On exam, you may palpate what's known as the sausage-shaped mass in the abdomen, and that's the intussusception itself. You're feeling that. The patients can come in shock with hypoperfusion, tachycardia, hypotension, things like that. Barium enema is the best way to diagnose intussusception. Barium enema is the best test because it does two things. It'll diagnose it, and you'll look for here, you see what's known, here's the barium coming up, it goes across, and it stops. Okay? And it's known as the coil spring sign. Coil spring sign. So barium enema will diagnose it, but also many times barium enema, the hydrostatic force of the barium enema will reduce it. It'll push that segment of intestine back out. If that doesn't work, or if it recurs, then you call the surgeon. So usually the surgeons are there watching while it's being done. And if it gets reduced, fine. If it doesn't, go to the OR. Okay? So that's the best test, is a barium enema. And again, it's filling up and then, okay, barium enema. And here is a section, it had to be, the surgeons went to get, and here is the part of the intestine opened up, and here you see the other part of it inside. And you can see where it can start to get necrotic because of the compression on the vasculature. Okay, your differential includes gastroenteritis. Gastroenteritis and intussusception are very similar at the beginning, but obviously gastroenteritis starts to resolve, and these guys get worse. Meckel's diverticulum can produce bloody stools, and Meckel's diverticulum can cause an intussusception. But usually, Meckel's diverticulum is painless bleeding. And Henoch-Schönlein purpura can produce abdominal pain and bloody stools and can also cause an intussusception. So that's part of your differential. And they're very common age range, too. This is a Meckel's diverticulum. A 2-year-old boy presents with a 1-week history of painless rectal bleeding. Physical exam is unremarkable. The abdomen is soft and non-tender. Rectal exam is unremarkable. So pretty normal, except that they've noticed some blood in the stool. It's the most frequent congenital anomaly of the GI tract. Remember that it is a remnant of the omphalomesenteric duct. It's known as the disease of twos. That's how you remember it. Okay? 2% of infants. 2 years of age. That's the peak incidence. 2 types of tissue. Ectopic gastric mucosa, right? 2 centimeters in size. 2 feet from the ileocecal valve. I think it's 2 to 1 in males too, but it's the disease of twos. Usually it'll start out as painless rectal bleeding, and they sometimes do describe current jelly stools, but usually it's just bleeding, painless rectal bleeding. It can cause an intussusception. It can mimic appendicitis if it's inflamed. And the best test is what's known as the Meckel scan, or it's a technetium scan. And technetium is taken up by gastric tissue. So what you're going to see is, since this is ectopic gastric mucosa, you will see when you give the technetium, it'll be taken up in the stomach, but you'll also see it in the abdomen, lower down. Okay? So the best test, if you're suspecting this on the question, they'll say you suspect Meckel's. The next step would be order a technetium scan or a Meckel scan. They won't say Meckel scan, but order a technetium scan. And treatment is going to be surgical removal. That's a Meckel's diverticulum right there. Okay. Rye syndrome. An 8-year-old is seen in the emergency department with persistent vomiting and mental status changes. On exam, he is combative and has a seizure, becomes apneic, and requires intubation. Laboratory tests are remarkable for hypoglycemia and elevated ammonia. The patient had recently recovered from a viral upper respiratory infection. Okay? So you don't see Rye syndrome much anymore. One of the reasons we don't see Rye syndrome much anymore is because we don't give aspirin to children who have viral infections. That's one reason. Okay, so that in the old days, the typical question would be, you just got over varicella and have been taking aspirin for fever or something. Okay? We don't do that anymore. We don't give aspirin to children with viral infections. Another reason we don't see Rye syndrome anymore is that we've gotten better at diagnosing other things, other mitochondrial diseases or whatever, or liver diseases that mimicked Rye syndrome. So the incidence has definitely gone down, but it's still there. So it's an encephalopathy with fatty degeneration of the liver. Look for a history of a recent viral infection, be it an upper respiratory infection or chicken pox, something like that. They may throw in aspirin or not, probably not anymore. So look for a recent viral infection. So a child that has been fine and a week after getting over this stuff starts to have mental status changes, vomiting, things like you should start thinking of Rye syndrome. So after 5 to 7 days, they will present with abrupt onset of protracted vomiting. They can progress to delirium, combative behavior, stupor. Hypoglycemia will occur. And you're going to think of Rye syndrome when you see these things, and you have the stages of Rye syndrome there in your notes. Okay? So you'll have a stage 1 is lethargy, vomiting, sleepiness. Stage 2 is confused and lethargic. Stage 3 is decorticate. Stage 4 is decerebrate. And stage 5 is flaccid with apnea but still reactive pupils. You're going to lab tests. Well, a patient like this, you're going to suspect, especially when they come in with the vomiting and the mental status changes, what's part of your differential diagnosis? Encephalitis. Remember we said encephalitis versus meningitis. Encephalitis, they tend to have more mental status changes. So you think of encephalitis and maybe you should do a spinal tap, right? So you do a spinal tap. And you're not going to get anything on a spinal tap. Okay? But you will have a normal CSF. However, ammonia tends to be elevated in the blood. And your transaminases will be elevated. So will your CK and your lactate dehydrogenase. And hypoglycemia. So those are hallmarks of Rye syndrome. Your prothrombin time may be elevated, and a liver biopsy shows fatty infiltration. That's not the first thing you're going to do, though, right? Liver biopsy is not the first thing you're going to do. You're going to get all these other blood tests first. And the treatment is basically supportive. Treat the hypoglycemia, treat the seizures, get an airway. And you need to think of other causes such as encephalitis, an ingestion, a toxin. Those are similar presentations. Okay? All right. Next chapter. A 2-year-old girl presents with a urinary tract infection. She has had multiple urinary tract infections since birth, but has never had any follow-up studies to evaluate these infections. Physical exam is remarkable for an ill-appearing child who has a temperature of 40 degrees centigrade and is vomiting. What's putting this girl at risk for these multiple urinary tract infections? In this particular case, it's vesicoureteral reflux. So what is that? That's just that urine is having an abnormal backflow up towards the kidney from the bladder. It can be caused by congenital incompetence of the vesicoureteral junction. It can be familial. And it can be secondary to urinary tract infections. And remember, we'll talk about urinary tract infections, and well, right now we might as well. In the first year of life, urinary tract infections will be more common in males. And after that, it becomes more common in females. There is a 10-fold difference and urinary tract infections between circumcised and uncircumcised males. The overall, that sounds kind of scary, right? But uncircumcised males, 1% incidence of urinary tract infections. Circumcised males, 0.1% of urinary tract infections will have urinary tract infections. So the numbers are really low anyway. Okay? But there is definitely a difference between circumcised and uncircumcised as far as urinary tract infections. But again, once you're past 1 year of age, it's much more common in females than in males. There will be incompetence with VU reflux. There will be incompetence of the junction due to infection and or obstruction. That means that whenever you void, the bladder pressure goes up and you'll have the backflow because of that incompetence. So urine comes out one way, but it goes up, backs up the ureters. It is a common cause of hypertension in children. Remember we talked about hypertension yesterday, and we said in young children, look for a cause. Most of the time, it'll be a urinary problem. In older children and adolescents, it's like in adults, hypertension. Okay. Usually, reflux is found when you're evaluating the patient for a urinary tract infection. So in this question that we had, the patient had never been evaluated until now, and now you're going to find the reflux. That is part of your evaluation of urinary tract infections is going to be a voiding cystourethrogram and an ultrasound of kidneys and bladder. Okay. So reflux is in different stages. The stages are 1 through 5. Stage 1 means that you just have reflux, but there's no dilatation of the ureter. Grade 2 is reflux into the upper collecting system. You'll see it. I'll show you a picture in a second. Reflux is all the way up to the collecting system without dilatation of the kidney. Grade 3, you start to see some dilatation of the kidney. Grade 4, the ureter is grossly dilated. Grade 5, it's tortuous. Okay, so this is grade 5. And this is what you see. So you have a little bit of reflux up this way, and this is grade 5 reflux on the left-hand side. Okay? So we have a very tortuous ureter, and now you have a big dilated kidney. So this is grade 5 reflux. And this is hydronephrosis. Okay? So that's probably what's happening with this girl, I bet, in this question. So you need to diagnose it with a voiding cysto to see how far back the stuff goes up. And you need to assess the kidneys with like an ultrasound to see if there's hydronephrosis. And then you can start determining what you need to do. Usually mild reflux, like a grade 1 or 2, in a child gets better as they get older, so they probably just need prophylactic antibiotics so they don't get a urinary tract infection. Grades 4 and 5 need surgical reimplantation of the ureters so that you don't get that reflux. So that would be the management. Okay? And you want to avoid renal scarring and nephropathy. That's why you do these things. Those are complications. Let's go back. Okay. A 10-year-old boy presents with cola-colored urine and edema of his lower extremities. On physical exam, I don't know why they picked Coca-Cola. Could have been Pepsi-Cola, right? I mean, Royal Crown. Cola-colored urine and edema of the lower extremities. On physical exam, the patient has a blood pressure of 185/100. He does not appear to be in any distress. Lungs are clear. He has a regular rate and rhythm without any murmurs, gallops, or rubs. His medical history is remarkable for a sore throat that was presumed viral by his physician 2 weeks ago. So yesterday we talked about strep pharyngitis. And we said, how do you tell the difference between viral and strep? You're going to do the culture, you can do the rapid screen and the culture. The culture is the gold standard. And we said you treat to avoid rheumatic fever. We said you treat to avoid glomerulonephritis, peritonsillar abscess, retropharyngeal abscesses. That's why you treat. Okay? In this particular case, they thought it was a virus, didn't treat. Now he's got glomerulonephritis. So always look for, when you're reading the test question, look for prior history of like a pharyngitis. Even sometimes treated, it can happen. Nothing's 100%. So 1 to 2 weeks after a streptococcal infection of the throat or of the skin, such as an impetigo, you may start having these symptoms. They will have the triad. Look for the triad of hematuria, edema, hypertension. These are the big three. So when you read your question, you see those three, you say, most likely glomerulonephritis, post-streptococcal glomerulonephritis. Patients may complain of fever, malaise, or abdominal pain, but usually they come in because of the hematuria. A urinalysis will show red blood cell casts and may show protein. You need to demonstrate past infection with group A beta hemolytic strep. The best test for that is going to be your DNase antigens. They may have some anemia. They may have a decreased C3. Antinuclear antibodies may be done to rule out lupus because they can cause renal involvement. A renal biopsy is usually not necessary if you have classic glomerulonephritis. So if they're, let's read this question, blah, 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 presumed physician 2 weeks ago. The best test, look for DNase to let you know that this guy had a previous infection. That's how you're going to prove that he had a previous infection with group A beta hemolytic strep. You should give antibiotics so that they can't spread this particular strain that attacks the kidneys, but it doesn't change the disease process. You just don't want them to give it to somebody else. And then you treat symptoms. If their blood pressure is 185 or over 100 and you're 10 years old, you probably need some antihypertensives. Okay? Watch their fluids. Generally, they get better on their own. They will have a remission. They can have renal failure, and again, you just treat supportively until they generally get better. About 95% will have complete recovery. You need to think about lupus, because in this particular case it was a boy, so that's not as common. But you need to think about lupus because it can cause renal manifestations in children. Also think of hemolytic uremic syndrome, glomerulopathies as part of your differential diagnosis. Okay, so look for hematuria, edema, hypertension. Allports. The school nurse refers a 7-year-old boy because he had failed his hearing test at school. The men in this patient's family have a history of renal problems, and a few of his maternal uncles are deaf. A urinalysis is obtained from the patient, which shows microscopic hematuria. So Allports is the most common type of hereditary nephritis, and that's why you have all this information about the mom's uncles, okay? Because it's X-linked dominant, although many times the women have just subclinical hearing loss. And you don't really notice it. So it's X-linked dominant, and that's why you have this history of the mom's uncles, because it came from the mom that this boy got it. Look for hematuria. Sometimes it's just microscopic hematuria. The biggies, the two big ones that you have to think about, because a lot of things cause hematuria, okay? Look for hearing loss and or cataracts. Hearing loss and or cataracts. And the physical exam is just like it says in the question. They really don't have symptoms except that they may have hearing loss and or cataracts. So this guy failed his hearing test. They will have microscopic hematuria and proteinuria. Renal biopsy should be done. And on renal biopsy, you'll see a thickened basement membrane. As they get worse, you'll see atrophy and what are known as foam cells. There's no therapy for Alports, okay? They will develop end-stage renal failure later and will need dialysis and eventually progress to renal transplantation. Again, women usually do okay and may have a subclinical hearing loss. So look for a male that's affected, and the key is going to be hearing loss and or cataracts. A 3-year-old child presents to the emergency center with a history of bloody diarrhea and decreased urination. The mother states that the child's symptoms began 5 days ago after the family ate at a fast food restaurant. At that time, the patient developed fever, vomiting, abdominal pain, and diarrhea. On physical exam, the patient appears ill. He is pale and lethargic. Okay? So again, important things to glean from the question: bloody diarrhea, decreased urination. Okay, so now we've got bloody diarrhea and we're starting to get oliguria. Is he just dehydrated or is he going into renal failure? And you have a history here of eating at the fast food restaurant, and then he got basically food poisoning, right? Fever, vomiting, abdominal pain, and diarrhea. And that was 5 days ago, and now he's really sick. So, there's different things that can cause hemolytic uremic syndrome. It's not just E. coli, but that's the hot topic, is E. coli, O157H7. Okay? And it would be transmitted by undercooked meat or unpasteurized milk. So that's where they throw in this bit about fast food restaurant. Basically, with undercooked meat, it's going to be basically undercooked hamburger, right? You should have your hamburger medium well to well. Your steak really doesn't matter, okay? Because when your steak, if it's on the steak, it's on the surface. So when you put it on the grill, it's hot enough to kill the E. coli. The problem with the hamburger is you grind it up, and so there's E. coli. With the steak, it's only on the surface. With the E. coli, with the hamburger, it's inside in the middle too. So you have to have it cooked all the way through. It's also been associated, hemolytic uremic syndrome has been associated with other bacterial and viral infections. So contaminated swimming pools, apple cider, okay? It's been associated with other things, but the hot one now is the E. coli. And you're going to have problems with the kidneys, problems with clotting, anemia. So look for, usually it's a child less than 4 years of age. They may have had a gastroenteritis. They may be recovering from a viral gastroenteritis. They may have had bloody diarrhea, or even something as simple as an upper respiratory infection. And in 1 week after these symptoms are getting better, the patient can have oliguria, and they get pale because of their anemia. They get weak and lethargic. Okay? You may, on physical exam, see a dehydrated patient. You will see a dehydrated patient on physical exam. And they can have hepatosplenomegaly. They may have petechia because of the coagulopathy that they have. Okay? So, suspect it with acute renal failure and a hemolytic anemia. So, you're going to get basically, your basic stuff is your CBC, your electrolytes, BUN, creatinine, urinalysis. Those are the basic things that you're going to get initially. The white count will probably be elevated. Your hemoglobin is low because they're anemic. And the platelets will be anywhere from 20 to 100,000. So you'll see leukocytosis, anemia, thrombocytopenia. And on peripheral smear, important, helmet cells or Burr cells because of the hemolysis. But your Coombs test is negative. And then your urinalysis shows hematuria, proteinuria, and you'll have increased BUN creatinine, indicating your renal involvement. Treatment is symptomatic supportive. Okay, so you need to rehydrate them. You need to treat the renal failure. And patients will survive with good intensive care. Okay? So there is no best test. It's a variety of things that you're going to have to see, and they'll probably just give you that information on the question. They'll say, okay, CBC shows this, BUN and creatinine are this. Complications include anemia, hypertension, acidosis, heart failure, diabetes, seizures. Don't know how those are related to the initial insult, though. And again, it's just going to be supportive care. What's your differential? Thrombotic thrombocytopenic purpura, but that's usually young women. They will have fever, decreased platelets, and some skin manifestations. Lupus and malignant hypertension. Bilateral renal vein thrombosis, so it's basically your differential of renal failure. This is a child with nephrotic syndrome. Okay? A 3-year-old presents to the physician with the chief complaint of puffy eyes. On physical exam, there is no erythema or evidence of trauma, insect bite, cellulitis, or conjunctival injection, or discharge from the eyes. So the eyes actually look normal. He's just puffy. Okay? When you examine this child, you see that this particular child, it's not just the eyes that are puffy, his whole face is puffy. Look at the feet. Look at the feet, how puffy, how shiny the skin is because it's stretched out. Okay? And many times the parents bring the child in because the eyes are puffy in the morning, then it gets a little bit better. But the other thing that they'll notice is that, for example, the underwear and the socks leave marks on the skin, and that's from the edema. So look for those things too. It's a generalized edema. Many times in the question you will see something about having had or having recovered from an upper respiratory tract infection. So many times nephrotic syndrome also occurs, like many of these other things, after having had some kind of viral thing, okay, a cold, something like that. Look for, as you're reading your question, proteinuria, hypoalbuminemia, edema, and hyperlipidemia, because they may give you some lab results, and you're sitting and go, the urinalysis, since he's puffed, urinalysis reveals, you go, oh, protein, oh, the albumin. And then they're going to get some blood work, and you'll see, oh, his lipids are high. His albumin is low. So those are the 4 things you look for. Okay? Nephrotic syndrome is classified as, the most common is idiopathic, which is also known as minimal change disease, being the most common of them. And you can have a glomerulonephritis, where they have what are called nephritic nephrotics. So glomerulonephritis can lead to nephrotic syndrome. Majority of patients will be idiopathic, however. 85% of all nephrotic syndrome will be what's called nil disease or minimal change disease. It's more common in males, and it's usually 2 to 6 years of age. And what happens is, for whatever reason, you're going to have increased glomerular capillary wall permeability. That's going to cause you to lose protein, right? Since you lose protein, you start to lose oncotic pressure, so you get your edema. Hyperlipidemia occurs because of the decreased protein stimulates protein synthesis, and one of the proteins that you make is a lipoprotein. So you have hyperlipidemia. And you also have a decrease, since your losing protein, you have a decrease in your lipoprotein lipase, and that leads to hyperlipidemia. You're not breaking it down. Look for a viral upper respiratory tract infection. Then they will show up with either pitting edema or generalized edema if they've waited long enough to come in. The patient can be tired, loss of appetite, and they complain of abdominal pain. Usually they don't have hypertension. And most of the times they've gained weight just because of the excess fluid. Get a UA. Okay, I'm sorry, I skipped something. An exam, edema, and they may be somewhat dehydrated because it's basically third spaced. And they can't have pleural effusions because of the hypoproteinemia, and they can have ascites because of the hypoproteinemia. Get a urinalysis, and you will see proteinuria, hematuria, and get some blood work so you can find out what your albumin is and what your lipids are. If they're asking you to order tests, those are the ones you order. C3 will be normal. C3 is low in glomerulonephritis. C3 is normal in nephrotic syndrome. Know those so you can tell them apart. Treatment is usually just diuretics and salt restriction. You may give albumin. Steroids can help. Renal transplantation is rare. You don't hardly, since most patients have minimal disease, you don't go that far. Okay? Now, complications. This is important to know. Infections. So they may give you that whole blurb, and they might ask what's the patient at risk for, and not ask any of this other stuff. Infections, particularly spontaneous bacterial peritonitis, usually caused by strep. So you need to worry about giving them pneumococcal vaccine. They can have arterial and venous thrombosis. Most children do well, because most of them have minimal change disease. They do well. They may have remissions and exacerbations, and then it finally goes away. But as far as complications, spontaneous bacterial peritonitis. Okay, and the last one is urinary tract infections. A 12-day-old infant presents with fever of 39 degrees centigrade, vomiting and diarrhea. Physical exam is ill and mildly dehydrated. Okay? Wow, that could be a lot of different things. Vomiting and diarrhea and fever in a 12-day-old. So what's your differential? What do you think about? Sepsis, right? Group B strep, listeria, E. coli, right? Meningitis, pneumonia, urinary tract infection. We've mentioned it as part of the evaluation of an infant because of very non-specific presentation. So this child has fever. Part of your evaluation is you're going to get a urine culture in addition to, he's going to get a spinal tap, he's going to get a chest x-ray, blood culture, CBC, urine culture. Your urine culture might show something. Okay, so urinary tract infections. Pyelonephritis, that involves the upper urinary tract. Cystitis, it's an infection involving the bladder. And asymptomatic bacteriuria, which means that you have a positive urine culture, no symptoms, okay, and no renal injury, thank goodness. Urinary tract infections, E. coli, number one. Okay, Klebsiella proteus, that's down the line, but E. coli is the most common cause of urinary tract infections. Okay? Viruses can sometimes cause infections, particularly cystitis. But always think of a bacterial cause in children. Think of E. coli. Okay? Again, more common in males as infants. Later on, it's more common in females. And the presentation depends on the age. A 12-day-old can't complain of dysuria. Right? A 12-day-old, frequency, enuresis in a 12-day-old, no. So it depends on the age. So when you're reading your question, you have to know the ages. Children, infants with UTIs may present with unexplained fever, failure to thrive, weight loss, vomiting, diarrhea. Older children will have fever. They may complain of abdominal pain. They may tell you that they're going to the bathroom more often or it hurts when they go to void. They may have enuresis. Now, pyelonephritis, they look sicker. In an older child, they will complain of flank pains. They will have chills, higher fevers. The best test to diagnose a urinary tract infection is urine culture. Okay? Don't get sucked into a urinalysis or leukocyte esterase or nitrites or blood or WBC. No. Urine culture is the best test. Okay? All the other stuff is helpful, but the best test is going to be a urine culture. The treatment will be antibiotics. This baby is sick enough, needs to be admitted, get IV antibiotics. We're waiting on your cultures. So the treatment will be antibiotics, and you treat anything else like this if they're dehydrated or anything like that. Okay? Now, you need to, once you start treating them, you should repeat your urine culture to make sure that you've sterilized the urine. So after a few days to a week, you repeat your urine culture to make sure you've sterilized the urine. Follow-up of these patients. What do you do as far as follow-up? That takes us back to this the first question in this chapter about that girl that never had a workup. Okay? Any male at any time who gets a urinary tract infection requires a voiding cystourethrogram and an ultrasound. It requires imaging studies because you want to make sure that you don't have posterior urethral valves or any kind of anatomic abnormality or reflux. Most of the studies are negative, but you don't want to miss them. Okay? So any male at any time, first infection, that's what you do. Okay? Girls under the age of 5. Any girl under the age of 5, first time infection, documented infection, same workup. Look for an anatomic cause. Older than 5, you let them have a second infection before you work them up. Because now they're responsible for their own hygiene. Maybe they're not doing things right. They need to be taught proper hygiene. So you let them have a second infection before you work them up. Once you get a urinary tract infection, you're at higher risk to get another urinary tract infection. So you need to monitor and make sure that they don't get another one, particularly with a case of asymptomatic bacteriuria. So generally what you do is you get monthly urine cultures for like 3 months. If those are negative, then you get them every 3 months for a year. And if those don't grow anything, then you get them yearly. Okay? Okay. Children who show reflux, like we said, if it's mild reflux, you're going to treat them with empiric antibiotics to see if they outgrow this reflux. If it's severe reflux, grade 4, grade 5, they will need surgical reimplantation.